Thank you so much, Brendan, for such an insightful and thought-provoking welcome to country. It's my great pleasure to introduce someone whose voice brings a critical perspective to our work as researchers and clinicians, Dr. Marta Woolford. Dr. Woolford is a clinician, researcher, and she's a passionate advocate for people living with dementia and their carers. Her work focuses on improving dementia care, support, and lived experience for individuals and families navigating the challenges of dementia. Today, Marta will share perspectives on caring and the importance of supporting carers in the dementia journey. Please join me in welcoming Dr. Marta Woolford.
Good morning, everyone, and thank you for giving me the opportunity to share my experiences and the impact that Alzheimer's disease has had on my mum and all those that love and care for her. But before I do, and I hope I'm saying this correctly, I would like to acknowledge the history of the lands and pay my respects to their elders past and present. I'm here today wearing two hats. One as a carer of my mother, who is living with very advanced Alzheimer's disease and since January this year has moved into permanent residential aged care. And the other is that of a dementia and aged care researcher that deeply values the work researchers are doing in this space, both from a personal and professional perspective. Our journey with my mum's Alzheimer's disease began 8 years ago. At that time, Mum was diagnosed to be at the moderate to severe stage of the disease. I still remember the feeling of shock when we left the geriatrician's rooms following the diagnosis. My mum was angry, believing she had been misdiagnosed. After all, she was only 70 years old. It broke my heart to watch her feel so ashamed of having the disease. She asked that we tell no one, and she also asked whether we would still want to be around her. The impact of stigma for dementia rippled through my mum and broke her, and she felt deeply ashamed. I had emotions of guilt that I didn't encourage Mum to get tested sooner, and how could I have let this go this far? After all, the changes we were seeing in her didn't seem to add up to a moderate to severe diagnosis. An earlier diagnosis would have helped us to adjust and plan better for the changes. The 15-minute appointment we had with the geriatrician with a check-in appointment 6 months later wasn't enough and left us confused. We must continue to invest in research on risk factors, stigma, early diagnosis and prevention. These are ongoing critical research areas. Over the 8 years Mum lived at home, her cognitive, physical, social and everyday care needs increased. For example, at first, Mum could help me prepare dinner with instructions. This progressed to no longer being able to follow instructions, nor recognise utensils, foods, her family and her own environment. This decline occurred in all parts of her life, to the point where we could no longer provide the support she needed. We were fortunate that we were able to use our ageing and dementia knowledge and seek support from services like Dementia Australia to help Mum continue to live a life of value and purpose. But it was challenging and we need to do more. There continues to be gaps in wraparound services for the person and for their carers throughout the entire dementia journey and the multitude of changes that occur. And this also includes the demand of administrative processes that are required, which can be overwhelming for many. Now, Mum lives in permanent residential aged care. As her Alzheimer's progressively worsens, challenges for the provider are ongoing. We need more research to build sector-wide knowledge on how to provide the best dementia care, supportive environments, and regulatory guidelines. Caring for a person living with dementia challenges you as a person, no matter how strong you are and how much information you hold. I miss my mum. I miss her wisdom, her sharing of wonderful stories as a child psychologist, and I wish that the memories I have with her are continued experiences. So today, as this forum begins, I want to acknowledge the extraordinary value of your work. I want to thank you for your commitment to understanding ageing and dementia more deeply, and for striving to improve the lives of people living with dementia and their carers like me and my family. And I want to encourage continued and increased investment in this research. We need to do more for current and future generations, and I know we can. Thank you.
Thank you so much, Marta, for sharing such an important story with all of us. And it's such an important reminder of why we do what we do. I would now like to welcome our chair for our next session, Professor Amy Brotman, to the stage to introduce our first keynote speaker.
Thanks, Stephanie. Thanks, everyone, and welcome to the Australian Dementia Research Forum. Thanks, Marta, as well. That was very moving and important knowledge. And I think he's left, but thank you, Brendan, and I thought that was an extraordinary welcome to country, and I think it gives us all pause to think about the injustices and the entrenched racism that continues to exist in our country, and I acknowledge that we're assembled on the stolen lands of the Gadigal people, and I acknowledge elders, past, present and emerging in the audience. Thanks. So our next speaker and the keynote for this particular session is Professor Perminder Sachdev, who I'm sure many of you know. He's a Scientia Professor of Neuropsychiatry and co-director of the Centre for Healthy Brain Ageing at UNSW, where he's been for many decades doing extraordinary work. He's Research Director of the Neuropsychiatric Institute at the Prince of Wales Hospital and Director of the Centre of Research Excellence in Vascular Contributions to Dementia. His major areas of research are drug-induced movement disorders as a psychiatrist, brain imaging, cognitive ageing and dementia. And he's very interested in vascular cognitive impairment, which he's speaking on today. He's published over 900 peer-reviewed journal papers and 6 books, including one for lay readers and a book of poems as well. In 2011, he was appointed Member of the Order of Australia for services to medical research. He was also awarded the Ryman Prize in 2022 by an international jury for the most significant contributions worldwide towards the health of older people. And last year, he was awarded the ADNET Lifetime Achievement Award. Please join me in welcoming Perminder.
Good morning. Thank you, Amy, for the kind introduction, and to Stephanie for the invitation. I think it's probably one of the few dementia meetings where vascular dementia has been the opening session. I can't think of any other meeting I've ever attended other than the VASCOG meetings. So I think that's quite a shift, and very encouraging for me, at least, because that's been my major area of interest. So what I would like to do today is to basically take you through the journey in vascular dementia and look at where we are at and where we need to go, perhaps, in relation to this area. This is the age of hegemons, I know, and in the dementia field, Alzheimer's disease has been the hegemon for a long period of time. And I think we need to perhaps challenge that hegemony and have developments in other fields of dementia, which are perhaps equally important. People say that vascular dementia is the second most common form of dementia, but I think its contribution, the contribution of cerebrovascular disease is probably very important in perhaps 3/4 of cases of dementia. So its really role is far greater than the research interest and the investment in this field. So let me actually, I can't see my slides very well from here, so I'll just have to try to figure that out. Yeah, okay. That's better, yeah. Now I can see the slides, yeah. It's okay, yeah, it's okay. All right, so let me start with just the disclosures. There's really nothing, no conflict of interest to disclose, but let me go through vascular dementia's development historically. And perhaps there was a time, the late part of the 19th century, when senility was associated with hardening of the arteries, and arteriolosclerotic dementia was probably considered to be the most important mechanism by which dementia occurred. And perhaps we go back to Binswanger's earlier cases. He described 2 cases neuropathologically where he attributed dementia to small vessel disease. And in fact, it was Alzheimer that labeled it Binswanger's disease. However, that never took off. It was considered a very rare form of dementia. And just as Alzheimer's was considered a rare form of dementia until the 60s. It was actually following that work, initial work by Martin Roth and colleagues in the University of Newcastle in England, that Hachinsky published in the early 70s his work showing that when multiple infarcts happened in the brain, often people ended up with dementia, and labeled it multi-infarct dementia. When we were medical students, that was really the form of dementia we were introduced to as the major form of vascular dementia. But there had been a trend in recognizing small vessel disease as a major contributor throughout, and there were this notion of subcortical vascular dementia. However, formalization of the criteria for vascular dementia didn't happen until the early 90s. That's when Roman et al. Brought together a group, and they published the Nins-Aaron criteria for dementia, we'll come to in a moment. And that actually changed a few things. However, since then, there have been a number of developments, and I brought together a group in 2014 to actually look at the criteria, and this was under the auspices of the VASCOG Society, and we published the VASCOG-1 criteria. Those have been subsequently revised, and recently, in 2025, we published the VASCOG-2 criteria in association also with the World Stroke Organization, and we will go into some detail into those. So you can see that there has been an evolution of this. And one of the things that has confused people is the number of terms that have been used over the years. And we did a survey of the experts around the world in looking at the term that was most acceptable to people, and the majority voted for vascular cognitive impairment and dementia, VCID, and that's really the term we are taking forward. And we think that that's probably the term that perhaps will stick in relation to this disorder. So let's look at how we diagnose dementia. Now, many of you are familiar with multi-infarct dementia. It was described as a disorder which had a fairly acute onset and a stepwise progression. So with each stroke, you basically had a slight decline, stepwise over a period of time. And you can imagine with multiple strokes happening in the brain, there could be patchiness of cognitive deficits depending on where the stroke was. And there were often subcortical features associated with it. And there were focal neurological deficits, which you can expect from a stroke, and psychiatric symptoms were commonly described. And you can imagine also that since stroke is the second most common cause of death, that mortality was quite high in multi-infarct dementia. In fact, much more so than Alzheimer's disease in the earlier studies. And Hachinsky also published this scale called the Hachinsky ischemic scale, which basically was used roughly for a long period of time to distinguish between Alzheimer's disease and vascular dementia. And you can see the scale has items which look at both history as well as physical examination, mental state examination, as well as risk factors. So it's basically a combination of a large number of different variables. But you look at the sensitivity and specificity of this, it is not very high. And its utility is very limited, and that's really why it has not really gone forward very much now, lately. Now, the four most commonly used criteria for vascular dementia in the past have been these ones. I referred to the NINS-AREN criteria. Then around the same time, the California criteria or the ADRF2026 criteria, and then the DSM-4 and DSM-5 later, and ICD-10 criteria were published. Now, the NINS-AREN criteria have been used in a number of trials for dementia. And I think the important thing to remember with these criteria is that, firstly, of course, you make a syndromal diagnosis of dementia. That diagnosis was still based on the presence of memory disturbance as a necessary feature of dementia, which is what Alzheimer's disease had done to the field, really. There was an Alzheimerization of the concept of dementia. And that wasn't challenged in these criteria. But certainly there was an acceptance of small vessel disease as playing a significant role. And also by then, MRI was quite prevalent, so MRI features were significant in terms of defining the substrate for dementia in these criteria. However, the concept of vascular cognitive impairment recognized that vascular cognitive impairment dementia developed over a long period of time. And often this was several years. And there was a continuum of cognitive impairment that was associated with vascular pathology. So you could have an early stage, which was mild cognitive impairment related to vascular pathology. And then, of course, the preclinical state, when you recognized cerebrovascular disease, but the patient did not have cognitive impairment or concerns about cognitive impairment. And the idea was that whether we could develop significant biomarkers to come to that stage, because that is the stage when prevention was likely to be most effective. And I think that really has gone into the criteria that we now look at, the VASCOG-2 WSO criteria, where we recognize this continuum. And we still try to categorize it, because that's what diagnosticians generally or clinicians want, categories, but on the basis of an underlying continuum. And when we try to go through these criteria, we actually follow a few steps. And these are the steps. We try to initially establish a syndrome. We then look for evidence for a predominantly vascular etiology. We look at the level of certainty for this association, presence of alternative or comorbid pathologies, and then associated neuropsychiatric symptoms. So if you follow these 4 steps, this is our 5 steps. These are the ones that the clinician would like to use. So initially they would say, okay, is there a syndrome of dementia or mild cognitive impairment present? And that is based on presence of significant cognitive decline from concerns from the patient or informant, and clear evidence of cognitive impairment on objective testing. And then, of course, for dementia, the deficits have to be significant enough to interfere with independent functioning in the community. And for mild cognitive impairment, you have the same, but at a modest level, and you have still insufficient decline to interfere with independent functioning, although higher level functioning may need extra effort and assistance. But the important thing is, how do we then consider that this is vascular in origin, which is the next step in our determination. And this could be based on clinical features as well as neuroimaging currently. And of course, neuroimaging is not always available, and we still should be able to make a possible diagnosis of VCID. So for the clinical features, of course, if there are strokes present, you can try to relate it temporally to the evidence of the occurrence of a stroke, or other evidence that the stroke has happened, even though the patient may not have presented to ED or a physician for that. Those would be physical signs consistent with a stroke. But if there is no history of stroke, then some of the clinical features in terms of neuropsychological domains that are affected may be relevant. And here we find in the early stages especially, it is information processing speed and frontal executive function that seem to be affected. Of course, as you move later in this continuum, there is a range of cognitive domains that are affected. In fact, the picture is quite heterogeneous. And then, of course, we actually usually go to imaging. And there, of course, the preference is for MRI rather than CT, although CT may be indicative as well. So you want to look for multiple infarcts or a single strategic infarct. You want to look for multiple lacunes outside the brainstem, or one lacune sufficient in strategically placed location. And I've listed some of the strategic locations where infarcts or lacunes may be significant in terms of producing cognitive impairment. And of course, white matter hyperintensities, which we commonly see. And of course, we want to look at the severity of these white matter hyperintensities and the level of confluence and extension of these lesions. And then we want to look at any hemorrhages, the multiple hemorrhages or a single strategic hemorrhage. And we'll look at some of these examples in a moment. Now, the problem is that you often will expect a patient with Alzheimer's disease to have an insidious onset and memory impairment as being an early feature. Now, sometimes in vascular cases as well, you see insidious onset. Of course, there, if episodic memory is the predominant disturbance, then you actually go towards Alzheimer's disease as the most likely diagnosis. Now, if motor symptoms are present earlier on, then of course, that's another thing that probably suggests an alternative etiology. And other, if there is, of course, another primary neurological symptom. But neuroimaging is a big guide. And if you do not see good evidence for vascular pathology or possible vascular pathology or neuroimaging, that, of course, is something that makes you think of alternative etiologies. Nowadays, of course, we also have biomarkers for some dementias, in particular Alzheimer's disease, with PET, CSF, and blood biomarkers now. And if they are available, then that assists you in looking at either alternative pathologies or additional pathologies in this patient. And then, of course, we want to decide on the level of certainty. And we would make a diagnosis of probable VCID if we have good evidence from neuroimaging currently that there is significant vascular pathology that could explain the cognitive impairment, or there is a genetic disorder. Now, genetic disorders the autosomal dominant in genetic disorders are uncommon, or monogenic genetic disorders. But I do remind people of CADASIL as a possibility, especially if you see stroke, migraine happening in somewhat younger people with cognitive impairment coming later. I point this out because we often talk about autosomal dominant Alzheimer's disease within the context of Alzheimer's disease. We know it's very uncommon, but still it has guided us significantly in terms of our understanding of Alzheimer's disease. Similarly, I think some of these rare disorders, and CADASIL is quite rare, but there may be maybe 400 or 500 individuals, we think, in Australia with CADASIL. But it is a model that we sometimes use. There are a few other genetic disorders that rarely can produce cognitive impairment and dementia. But if you have neither of these, either good imaging evidence present or genetic evidence, then you would, of course, not make a diagnosis of probable dementia, probable vascular dementia, be a possible diagnosis. Now, the other thing to remind you is that vascular cognitive impairment often occurs in the context of other pathologies in the brain, and then you have to make a diagnosis of mixed dementia or multiply determined dementia, however you want to label it. And there, Alzheimer's disease is often the most common pathology associated. And then finally, I would like to remind people that we see a lot of patients in the clinics who have significant cerebrovascular disease, often they manifest in the form of white matter hyperintensities or lacunes, who do not come for cognitive impairment, who come for other reasons. And I think that's what is the people at risk or preclinical, and increasingly the focus is moving towards this covert cerebrovascular disease, usually small vessel disease, where we can probably do a fair bit in terms of prevention. Now, I won't spend much time on cognitive domains that are affected, because these are the ones that we look at in our determination of the cognitive profile of the individual. And recently, my colleague Adam Bent-Velzen put together an international group to try to look at some neuropsychological tests that could be used globally to map vascular cognitive impairment. And I've already referred to this profile in terms of processing speed and executive function being the early features. But of course, memory is affected, but the nature of memory impairment in vascular dementia may be somewhat different from that we see in Alzheimer's disease, where in Alzheimer's disease, you see rapid forgetting, whereas here, often cueing helps individuals in VCID in terms of getting back some of that information. So it's more a frontally determined memory impairment, although hippocampal involvement does occur in many cases, so the picture is quite heterogeneous. Here, of course, I think a number of studies have shown, in fact, we showed in our Sydney stroke study as well, that when you actually look at dementia cases, you find that when you try to determine which lesions in the brain are more significant, and this was a post-stroke study, still we found that it was a small vessel disease that was the most important determinant of cognitive impairment, even in the patients who had strokes. Now, how common is VCID? We think that it accounts for 15 to 25% of dementia cases. If you look at neuropathology, about 75% of all dementias have significant cerebrovascular disease, and in about 1 in 3, this is very important pathology, we think. And in fact, studies from the Chicago group, these are the Religious Order Study and the Memory and Aging Project called the ROSMAP studies, These were basically longitudinal studies with pathology at the end. They showed that, in fact, about 20% of these brains that came to autopsy had only vascular pathology in their brains. Not all of them had cognitive impairment, suggesting that pure VCI is not that rare. And I think that's another myth that people have propagated, that we don't see pure VCI. And in fact, this was one of the things that came up in an editorial following the publication of the criteria as well, as to where are these people with pure vascular dementia. Important to recognize that there are a number of other settings. Of course, we think that it accounts, say, about 15 to 20% or 25% cases. The rates increase as we grow older, so 85 plus, the rates are higher. In post-stroke cases, dementia is about 20 to 25%. And this is studied, these are data that were put together by one of our PhD students, Jess Lowe, from a large number of international post-stroke studies. But cognitive impairment is actually in 1 in 2 people following stroke. So it is, to some degree, some impairment is very common in these people. Now, if you look at atrial fibrillation, rates are higher. You look at heart failure, and surprisingly, rates are very high in people with congestive heart failure. Acute coronary syndromes, aortic stenosis, these are other heart conditions. So there are some heart conditions that associate quite highly with cognitive impairment, and cardiologists are becoming increasingly aware of patients coming to their clinics and the importance of having this a high index of suspicion in relation to cognitive impairment as well. Now, I refer to this apparent paradox that came up in editorial, that where are these people if it is so common? And I think they're not necessarily coming to memory clinics. That's one of the things. They're often going to neurologists, they're going to behavioral neurologists or stroke cases, or they're going to falls clinics, they're seen by renal physicians, they're seen by cardiologists, and often not picked up very often by, or cognition is not the major focus in many of these cases. Now, in looking at pathophysiology, we don't have a lot of time, but first thing I want to remind you is, of course, you all know that brain is metabolically very active and uses 20% of the oxygen that we consume. And if blood flow goes down, there is some compensation, but below, say, about 20 to 25 mil per 100 grams per minute, decompensation begins to occur. And if it goes below 8 or 10, then irreversible damage occurs to the brain. And you all probably remember your anatomy, looking at the interior and posterior circulation of the brain. And interior circulation accounts for about 70% of the blood supply. And of course, the anastomosis that occurs on the surface of the brain. But what I wanted to point out is these penetrating arteries that arise from the surface, go down into the white matter and supply the basal ganglia as well. These are end arteries, and I think these are the ones, they become quite narrow, they become arterioles later, and they are affected in small vessel disease, especially related to hypertension, diabetes, etc. And that increases the vulnerability of the white matter because these are end arteries. The other thing to remember is that these arteries and veins or arterioles and venules have a perivascular space, which is a potential space, which is becoming increasingly important in understanding the clearance, the wastage clearance system of the brain, which has been referred to by some people as the glymphatic system, although that's not the only way waste clearance occurs from the brain. And that is coming to focus also in dementias, not just for VCID, but also for Alzheimer's disease. When you look at the pathology of these people, you find that often they do have, many of them do have infarcts. And cystic infarcts are not as common as lacunar infarcts, but also there are a large number of small infarcts which are microscopic. And of course, there's been some confusion, some debate as to whether these are agonal kind of in origin at the time of death, but increasingly with some imaging we find also that you can pick these microinfarcts. And they may be contributing significantly to cognitive impairment. Of course, there's several amyloid angiopathies. Hippocampal atrophy does occur in patients with vascular dementia, pure vascular dementia as well. So it's not true that if you see hippocampal atrophy, then it is Alzheimer's disease. So that's, I think, another myth that is propagated sometimes. But often these pathology reports do not look at white matter very closely, and I think that's one of the difficulties in interpreting some of these. But if you try to map the various lesions that are associated with vascular dementia, you can see that you have these large vessel infarcts, but you have the small vessel changes, you have these lacunar infarcts or lacunes, which may arise from infarction or from a small hemorrhage. You see white matter lesions, then you have microbleeds, and of course you may have larger bleeds as well. And when you actually look at the microscopic level, you see, of course, changes in the blood vessels, but you also want to see changes in the parenchyma related to these changes in the blood vessel. Of course, again, we can't go into the details today. But I wanted to take you through this figure to basically see how the pathophysiology flows in terms of course, you have the vascular risk factors, many of you are familiar with, the lifestyle factors, then of course age and sex, the demographic factors, and the genetic factors, and often it is polygenic, both in terms of stroke as well as small vessel disease, although, as I said, with small vessel disease, we do have these rare monogenic forms. And leading to, there is some overlap in causing small vessel disease as well as large vessel disease. But the pathology is different in the large vessel disease as opposed to the small vessel disease, where large vessel disease you see atherosclerosis as the most dominant pathology, and then thromboembolism occurring as a consequence of that. Whereas small vessel disease, you see arteriolosclerosis and as the major, and of course amyloid angiopathy as well. But other thing to point out is, of course, venous pathology often contributes to VCID, and that's another under-recognized form. But essentially, the result is either hypoxic injury or acute anoxia leading to energy failure, when you see damage due to hemorrhage, which is mass effect, as well as inflammation, as well as toxicity because of heme and other products. And then, of course, number of other processes come into play. And these include excitotoxicity, damage to the blood-brain barrier, neurovascular uncoupling, and other aspects such as inflammation, leading on to cell death, disruption of neural networks, and development of cognitive impairment. So this is the way we see the flow of the pathophysiology. And it's important to recognize the secondary mechanisms, because that's really where a lot of the action is in terms of finding remedies for prevention and treatment. Now, we've talked about biomarkers, we talked about neuroimaging, and I think that's really where most of the action is in terms of looking at biomarkers, both looking at large infarcts as well as the small vessel disease in white matter lesions, lacunes, perivascular spaces, microbleeds, cortical superficial siderosis, as well as hemorrhages, large hemorrhages. But there is a lot of activity now in looking at diffusion imaging, and there are a number of metrics, because you know that diffusion measures, such as fractional anisotropy and mean diffusivity, are affected very early on, even before you start seeing white matter hyperintensities and lacunes in the white matter. And there are a number of metrics that are available now. Traditionally, we've been looking at white matter hyperintensities in terms of these ratings, such as the Physicas 1, 2, and 3 ratings, depending upon how big these are and how confluent these lesions are. And some people have tried to look at trying to put all these different pathologies together to see whether we can get an overview on kind of a scale that represents the total pathology in the subcortical region. But these efforts have not been very successful in terms of capturing everything. In fact, I think the field is moving towards looking at diffusion measures. And one measure called the peak skeletonized mean diffusivity, or PSMD, is emerging as a significant measure. Of course, these are not yet available to clinicians, but it is a matter of time, I think, before we start using these measures. And other measures such as free water imaging and techniques such as cerebrovascular reactivity, we have to use a carbon dioxide challenge, although there may be other non-invasive methods in the future that may be applicable, are being developed as new imaging markers. Now, fluid biomarkers has been slow in this field, and there have been some attempts at CSF biomarkers. Again, these are biomarkers that target certain aspects of pathophysiology. You can see the blood-brain barrier integrity, or angiogenesis, or inflammation, etc. So and they're not specific. And I think that's been one of the difficulties. There is no biomarker currently available for VCID in this space. We did a review of blood biomarkers. There has been a lot of work done around this. And this paper was published 2 years or 3 years ago now. Then we have been looking at blood biomarkers. We picked 23 potential biomarkers from this review and have done a study looking at these 23 biomarkers in 900 case, a sample of 900 from 7 different cohorts around the world. So it's been a fairly major effort. The PhD student, Gurpreet, has been working on this. And we find that one biomarker in itself is not going to work. We'll need a panel of biomarkers. If you look at 7 biomarkers, you get a reasonable AUC to distinguish VCID from AD. Of course, that improves if you include cognition and also if you include demographics and sort of maybe you can probably add other aspects to it as you move on. But this is work that we haven't yet published, but we are on the threshold. And we're looking at whether we can reduce the number to maybe 3 or 4 biomarkers that could be used as a panel for a diagnosis. Retinal imaging is the other area that people are working on. I, again, want to bring you back to the importance of covert cerebrovascular disease. Patients you see who have white matter hyperintensities in their brains and come to you for other reasons that you should be alert to them. When we did a study in the 40s, we found that about 50% of people had at least some signal of small vessel disease in their brains. So we are looking at a long trajectory of development of small vessel disease, just as we do in Alzheimer's disease. And I think we probably should be intervening here. And there's a number of things that we can do in this space. The other thing I also point out with VCID is that there are a number of associated neuropsychiatric symptoms. And in particular, depression is quite common, apathy is quite common, and emotional lability is quite common as well. You can see the other neuropsychiatric symptoms as well in this cohort, but these 2 or 3 are the ones that I pick as being the most significant, and often we have to intervene for these psychiatric pathology. So I have run out of time to some extent. I'll take 3-4 minutes more, if you don't mind, Stephanie, and just remind you of the risk factors. I've spoken about the genetic risk factors. Here what I've done is I've looked at comparison of AD versus VCID in terms of these risk factors. There is some overlap between risk factors, and the reason for the overlaps is that there are some vascular risk factors, so-called vascular risk factors, that may be risk factor for Alzheimer's pathology as well. Of course, demographics is important because age is a risk factor for both. Genetic factors are very different, but there are, of course, the brain reserve factors, which are often related to lifestyle, that are risk factors for both dementia. Actually, risk factors for all cause dementia, because they are interacting with the pathology in the brain and producing the cognitive impairment. And here, of course, physical activity, complex cognitive activity, social activity, these are the ones that are very significant. Of course, alcohol use is another factor. Now, these are the vascular risk factors we've already spoken about. And here, I think midlife hypertension is the one that I highlight the most as something that is recognized by everybody as where we should be intervening. And that could be a risk factor for Alzheimer's disease as well as VCID. And of course, the others you're all familiar with. And these are other risk factors that with evidence that has been not as strong as the ones mentioned previously. Now, finally, my message to you is, if you see vascular pathology in the brain, do not ignore it. Assess the individual for risk factors. Assess for other possible consequences like depression, apathy, etc., and inform and intervene to control the risk factors as best as you can. I think that's the message. Now, in terms of how we intervene in vascular dementia, there are no specific drugs that are approved for VCID currently. We still use cholinesterase inhibitors and memantine, just as we do for Alzheimer's disease. There is some evidence, not particularly persuasive, that they may be beneficial. There is some evidence of cholinergic deficits in VCID. So I think that may be, or it may be because of concomitant AD. We don't fully understand that. There are no other drugs. So basically, we are intervening, and there we are really intervening for prevention, and we're looking at various stages in which the patient presents to us. Now, this, I refer you to a paper published in January in the Journal of American College of Cardiology. Two papers, actually, which are state-of-the-art papers. And this paper was led by Louise Goodall, who's a PhD student, a cardiologist, and looking at treatments. And the first paper is on the overview of VCID. So I can give you a reference at the end of the talk. In terms of the pyramid of interventions, lifestyle interventions, as I said, very important, cardiovascular risk factor control, and using multimodal interventions rather than just focusing on one thing. But cognitive enhancers, as I said, have a small role, donepezil or galantamine, rivastigmine, memantine. People do use them, but it's plus minus. Of course, you end up using psychotropics if they are indicated in these patients with neuropsychiatric symptoms. And there is a fair bit of development happening. We recently put forward this paper. We looked at all the trials happening in this space, VCID, around the world. This is a paper which Ying Xu, a postdoc working with us with Matt Lennon and myself, put this paper together, and you can see that there are the domains that these treatments are in go very, very much. But there are only few treatments that are addressing potentially the pathophysiology of VCID. Many of them are targeting cardiovascular pathologies. There are 62 agents being investigated in 88 trials, but limited number of trials in phase 1. So the pipeline is not very rich at an early stage. I think that's really the message. And many of the trials were started before 2020. So it's not that we have a rich pipeline, unlike Alzheimer's disease. So we need a lot more effort in this space to, especially with small vessel disease. That's really where the focus should be. Stroke, there is already a lot of focus in terms of development of treatments, and also the salvaging the brain after stroke. That's really the holy grail, really, in terms of intervention. But here, I think a lot more work needs to be done. And new drug discovery attempts are being made. We're taking some baby steps here as well in looking at new drugs for small vessel disease. And for further reading, I recommend some of these papers, which are fairly recent, that go through the stuff that I've spoken about today. So I think I'll finish here. Thank you very much for your attention. Happy to take any questions.
Thank you so much, Perminder. That was a fantastic overview. I have been given leave to go over a little bit in terms of time, because we did start late. So if anyone has any questions, please come up to the microphones and just say your name, and Perminder will answer all your questions. While people are making their way up, I'll just ask a couple. I was really interested to look at the schematic where you were talking about the effect of potential, the collagenoses and the changes in the venous system. Can you talk a little bit more about that, how you think that might be affecting lymphatic system and perivascular spaces?
Yeah, so I think that's not very well understood as to how the venous system is playing a role in this, but definitely I think the wastage clearance is probably the way it's likely to occur. Because if you look at the wastage clearance system, there is a periarterial system, there's a perivenous system, and of course we call it lymphatic because the end feet of the astrocytes, the glia, are involved in this, and of course the channels, the equiporin 4 channels are involved in transfer across from the arteries into the interstitial space. So that wastage is being carried in the perivenous system, and of course in the dura there are real lymphatics, but in the brain itself there are no lymphatics. Yeah. So in fact this perivenous system is actually draining into the lymphatics in the dura, and they are draining into some of the posterior nodes, in the cervical nodes. In fact, it's very interesting that there's been a lot of work recently from China when they are work from China where they're doing surgery to actually connect that drainage system from the deep cervical nodes into the veins to actually increase drainage as a treatment for Alzheimer's disease. In fact, there are at least 20 centers in China that are doing that surgery. I don't think we have any control trial now. They've just started a control trial. Previously, it was only anecdotes. So there is some story there, and I mean that is essentially because there is some evidence that A-beta 42 is drained through that system as well. So it's not just a general kind of it's not for VCID alone. There may be other wastage that is cleared through that system. Yeah.
Please, question from the audience.
Hi, Gideon Kaplan from Sydney. As you mentioned in your very interesting talk, a lot of the diagnoses of vascular cognitive impairment and dementia are reliant on deep white matter hyperintensities. Yet a lot of the studies that attempt to look for evidence of vascular disease in deep white matter hyperintensities in post-mortem studies find no link at all between deep white matter hyperintensities and vascular disease in the blood vessels. So do we really need to re-examine that link?
I wouldn't fully agree that there is no association. I think it's a difficult one to demonstrate, and there are a number of reasons for that. One is that you often have to rely on post-mortem MRI, and post-mortem MRI, if you don't do it soon after death, is not that reliable in actually picking these white matter hyperintensities. So otherwise, you're trying to relate white matter hyperintensities at maybe 1, 2, 3 years before death and trying to relate to pathology. So that's one problem. Secondly, I think we know that white matter hyperintensity, there is definitely an association, between white matter hyperintensities and hypoxic markers seen in white matter, and some of the demyelination that has been described. So I don't think that is true. There have been only few studies, I agree, in relation to this. I mean, there's some studies done from Sydney itself. There have been studies from Newcastle that have been reasonably good in that relationship. But I also would add that I agree that white matter hyperintensities are not specific for vascular pathology. They occur in Alzheimer's disease, they occur in frontotemporal dementia, you see them in dementia with Lewy bodies, and there's been some debate. People are trying to see whether you can distinguish, and there is now recently machine learning and deep learning have been used to try to distinguish between VCID-related white matter hyperintensities and AD-related white matter hyperintensities. Of course, AD produces CAA, which also causes white matter hyperintensities. So the picture is somewhat complex in that sense. Yeah.
Gideon, I think it's fascinating, and I agree, Chair's prerogative. There is actually going to be a systematic review on white matter hyperintensities and the pathology of them that will be hopefully coming out later this year, that I think answers some of that question. Next question.
Hi, thank you very much. Mark Hades, Deakin University, Ballarat. I continue the white matter hyperintensity discussion. As a clinician in a memory clinic, how reliable are the radiological reports about physique-as scores? Because there seems to be a debate, some are using 3, some are using 6, depending on whether they want to talk about subcortical or cortical. Is there any real firm ground on which the radiologists are actually really reporting their white matter intensities?
Yeah. So I think, I mean, you're absolutely right that radiologists vary a lot. And often they would dismiss some lesions as being consistent with age of the individual, or they'll say greater than what is expected for the person's age. That's usually the kind of report we get from radiologists. And we don't often get a physique-as rating. But what we do is we like to look at the scan ourselves, really. And often you find that you want to look at the extent, you look at the confluence of these lesions. We also want to look for lacunes. So often you find that there are lacunes that have been missed by the radiologists, and that lacunes are actually a more specific marker in that sense. And often you find that people with extensive white matter hyperintensity will have lacunes in their brains. So we certainly definitely look for that. The other thing is, of course, you want them to do a FLAIR imaging, and you want to do a whole brain FLAIR imaging with a decent protocol, which they don't always do if you don't ask for it. So without FLAIR imaging, you don't get a good impression of white matter hyperintensities.
Next question, Dimity.
Thanks very much for that talk, Perminder. As a GP clinician researcher, I was interested in your comment that a lot of the people with dementia are seeing non-GP specialists and maybe never ending up with a full assessment by someone who's qualified to do that. And I was thinking that this has a really big effect on the management of the conditions that they're seeing those people for, especially the self-management part, which may be affected by cognitive impairment. And I think it would be interesting for GPs to identify those people and get them assessed to the extent that we can do with bloods and a plain CT or MRI, and then referred off if it seems appropriate. And we're moving into maybe being able to order some of the blood-based biomarkers as well. But And so really, I guess this is a comment, but I'm interested in your thoughts. I've been working on audit and feedback in GP practices. GP digital literacy is improving, and we can now audit our patients. So we could audit all the people over a certain age who are going to some of these non-GP specialists and think maybe they should have some sort of brief assessment, and then if they're showing signs of cognitive impairment, we could do preliminary bloods and then send them off for further assessment. And that would be a systematic way to pick up some of these people who are actually cognitively impaired and not being identified. Have you got any thoughts on that?
No, I fully agree with you that GPs have a very important role to play. I mean, GPs often will pick up MRI abnormalities with they send a person for, say, for headache or something else, for incidentally, or work up for depression, for example. But also, if there is cognitive complaint, I think a workup is important. Yeah, absolutely. And there, I think there is a lot, as we can see from risk factors, that there is a lot that can be done in control of risk factors. And often these are underdiagnosed. Where hypertension, for example, is still not adequately treated in fact, a large number of people. In fact, about 50% of cases is inadequately treated. And diabetes is not well managed, and there are other reasons why, certainly in terms of lifestyle, etc., that we should be looking at people early.
Yes.
So I fully agree with you that more sort of assertive management of possible small vessel disease is important.
Thanks, Perminder. Yeah. That's a whole new area opening up. Thank you.
Absolutely. And last question.
Good morning, sir. Myself, Mukul Jain from India. The epidemiology of vascular dementia would be more in India because there is highest epidemiology of hypertension as well as diabetes plus tobacco usage. So if the policy would be different to find out, because we are delineating towards dementia, not towards vascular dementia. So we should focus toward vascular dementia pre-diagnostic criteria.
Yeah, so I mean, I'm not quite clear what the question is, but we certainly, I think in our conceptualization of, say, overall management of cognitive impairment, what we're trying to do in the field is moving towards early stages of mild cognitive impairment. And a workup at that stage is important. And we look at all these risk factors in these people, and we may or may not do imaging. And I think that's really where some of the change could possibly happen, that we may be looking at imaging and looking at cerebrovascular disease, which otherwise has not been picked up, definitely. So I think that our sort of index of suspicion is important, really, in terms of where we go in terms of interventions. And we probably have to have, we can't have nihilism in this field. I think that's really the important thing. It's changing. I think most people now recognize that we can't be nihilistic about cognitive impairment, and there is a lot that can be done, definitely. Certainly, I think the one thing that certainly I point out that there are some countries where vascular dementia is probably even more important. There are, especially in East Asia, vascular dementia has been, although that is, the epidemiology has changed over a period of time, but as stroke is better managed and hypertension is better managed. So in certain settings, it's even more important. Yeah, definitely. Yeah.
Thank you.
Thank you, Perminder. And if you could join me in thanking Perminder for a comprehensive overview of this work. Thank you. So we now have the break, and we'll be coming back at 11:30 back to the ballroom. And please come for St. Luke's Choir, who will be joining us at that time. Thank you, everyone.
Yeah, yeah, of course.
Thank you so much.
Is it tall famous?
Yes.
I'm expecting it. Where are you from? I mean, which university?
University of Canberra.
Okay, all right.
Yes.
That's in Australia, right?
Yes, in Canberra.
I'm
Have I
from
first?
Western Sydney.
Oh, okay. Lovely.
Yeah, we're famous and famous.
Pardon?
You know the university, right?
Hello, hello. Well good, well good. Yeah, all good. Yeah. Everyone get the lyrics? Jane?
I think Cole's going to get him. Where's Webshot? Come on, Jane, quickly. Move faster, Jane.
You've got your dancers and your trumpets.
That's right.
Are we sharing?
Jane, I'll grab another one in the one eye. Someone's pinched.
Could you just take a photo of me there with the choir? Sorry. Horizontal.
Good.
Yeah, oh what? Maybe she can sit. You can sit there.
This here, right here. Yeah, this is perfect here. Hi, good. Yeah, let me just check. Graham, just come forward and do a mic. We'll do a sound check. Graham, just do something. You'll have to adjust it a little bit. Great, fantastic. Irene, just do a sound check. Just come and sing a little bit of. Yeah, just do a little bit.
Vor der Kaserne, vor dem...
That's it. All right?
Okay.
That's good, that's good. 2, 3, 4.
Vor der Kaserne, vor dem großen Tor, steht eine Laterne und steht sie noch davor.
Good? Great. Karin, beautiful. Beautiful. Have a seat.
I've never sung to my
We can sit down here, Jen.
Okay, we're going to get a photo now.
Everybody's in their t-shirt. You got your t-shirt?
Matt's taking a photo. Look at the camera. Stop talking, you lot. Anyone think you have dementia? No. Yeah, that's it. Cindy's got it. Grab it. Cindy, Not from myself.
Sorry, Helen. So lovely, everybody. So lovely. So good to see you all. Really nice, really nice.
How many tunes? Oh, wow. Good. I heard you guys I was at the AGM last year, and it was great. We'll just give them 30 seconds to come in. Just note that some people are still coming in, so please do come in. There's lots of free spaces at the other end of the room if you'd like to come across. Hello everybody, and welcome again to the Australian Dementia Research Forum. My name is James Vickers, recently retired Director of the Wicking Dementia Centre. Recommend retirement to anybody and everybody. And it's my great honour to welcome and introduce this session, which is coming at you from many different directions this morning. So we're delighted in particular to welcome the St Luke's Memory Lane Choir. This is, they haven't performed yet, so hold the praise. But this is a wonderful community choir that brings together people living with dementia, carers, family, and supporters together through music. St Luke's Care is an organisation actually based here in Sydney, one that we know well through the Wicking Dementia Centre, having worked with them. And they have an excellent record of developing innovative residential and community programs that support people with dementia, as well as those that care for them. And the choir reflects the important role that creativity, connection and community play in supporting well-being and quality of life for people impacted by dementia. Through music, the Memory Lane Choir fosters joy, inclusion and meaningful social engagement in a supportive and welcoming environment. And I had the great pleasure of seeing the choir in action at the AGM of St Luke's Care last year, and I know that you're in for a particular treat. So please do welcome the choir to perform for us at this year's conference.
Thank you, everybody. We're going to do a little song called Fly Me to the Moon, and we have our own Louis Armstrong in the choir, Graham. So Graham, whenever you're ready, with Susan, let's do it.
I'll lead you to the moon and sing that song forevermore. I speak
And we have our own Marlene Dietrich in the choir as well. Karine, if you'd like to come forward, please.
Vor der Laterne, vor dem großen Tor, steht eine Kaserne und steht sie noch davor. Und werden wir uns wiedersehen, wenn wir vor der Laterne stehen, wie einst Lili Marlene, wie einst Lili Marlene. Vor der Kaserne, vor dem großen Tor, steht eine Kaserne und steht sie noch davor. Und werden wir uns wiedersehen, wenn wir vor der Laterne stehen, wie einst Lili Marlene, wie einst Lili Marlene.
Fabulous, fabulous. Thank you so much. And we have the words up for a good reason, so please join us for the next song, Nat King Cole, L-O-V-E. Matt, or to say, Cindy, to say a few words, just like brief? All right. Okay. Yeah, nice. And it's just such a joy for me to be able to do what I do with everybody. It's just, I'm very grateful. Right, we're doing a Still Call Australia Home now. And then I think one more song after that. Let's do this. So our last song for today is a beautiful song made famous by Louis Armstrong as well, called What a Wonderful World. And Graham, standing by with your beautiful trumpet.
What a wonderful world.
Thank you so much, choir, for that wonderful and very moving presentation to the whole conference. It's a really great way of providing some really positive energy to our conference and to make sure that we're focused on the things that we should be focused on. Also, thanks to our choir master, Robert Tyker. Thank you very much. And also to acknowledge again the support of St Luke's Care. CEO Cindy Woods is with us today. Our Matt McLean too has made a oh, there he is over there, Chief Operating Officer too of St Luke's Care. But again, thank you so much to the choir. You've done an absolutely wonderful, wonderful job, and it's been such a wonderful part of this conference, so thank you. Yes, please. Yeah. So just be a couple of minutes as we reorganise the lectern in the front of the room. So we might ask some of the hotel staff to come forward and to help. And I thought, Perminder, Sachdev, you might want to come and help with reorganising the lectern for us. That would be fantastic. So just give us a couple of minutes and we'll be set to go again.
You do an amazing job. Thank you. So much joy. Thank you.
What's your name?
Yeah, really thank you.
What's
very
your name?
much.
Sorry? What's your name?
Morgan. Phil's my dad.
Oh, yeah, exactly.
And my mum. So, yeah. I'd heard they've been coming, but yeah, to actually be there last week and today is amazing.
Thank you. Thank you so much.
So we might get started again so we don't run into the next session. bit of a change to the program. We were going to have Jane Alty do a plenary this morning, but she's now motivated instead to present her favourite show tunes. So we're looking forward to that presentation, Jane. That was a joke. Okay. But it is my particular pleasure to introduce Professor Jane Alty. Jane is a Professor of Neurology in the Wicking Dementia Centre and also a practising neurologist at the Royal Hobart Hospital. She specialises in cognitive neurology and movement disorders. Jane obtained her medical qualifications from the University of Cambridge, a Doctor of Medicine from the University of York. She's certainly worked in many prestigious hospitals around the UK as part of her training as a neurologist. So I guess it was obvious that her next career move was from the UK to the University of Tasmania. In fact, that was a very, very happy set of circumstances that brought her to Tasmania, and she's been an absolute powerhouse of both academic and clinical activity in our state, and has produced a number of highly valuable outcomes already across dementia as well as Parkinson's disease. A substantial part of her research investigates artificial intelligence, or AI, methods to detect and track the preclinical and prodromal stages of dementia and Parkinson's disease. She co-leads the Tasmanian Parkinson's Project, which involves 3,800 participants across Australia. She was one of the originators and key designers of the Parkinson's disease massive open online course, or MOOC, which has now attracted over 26,000 enrollees across 160 countries since it started last year. She developed the Ireland One-Stop Cognitive Clinic in Tasmania and also leads the BRAIN project, which stands for Bringing AI into Neurology. So please join me in welcoming Jane.
I seem to be missing the clicker, just wondered. So good morning, everybody, and thank you for that very kind introduction, and thank you to the organisers for inviting me today. It's a huge privilege to be here at the ADRF. And as I look around the room, I can see that we're really quite a mixed group. There are people here living with dementia, there are family members, the scientists, researchers, clinicians, and so on. But actually, despite those different backgrounds, we come together really asking the same question, don't we? And that is, how do we do this better? And for me, that's not just a professional question, it's also a personal question. My granddad had vascular dementia. And what I noticed with the power of hindsight is that years before he developed memory problems, there were other changes there. Changes that we missed at the time. And in a way, that's what this talk is about. What do we miss as humans? What could we do better? What might digital tools help us to do better? And it's absolutely wonderful to see the advances in the biological biomarkers, isn't it? New blood tests, new imaging tests. But today I'm going to be talking about another piece, which is the digital tools. How can they help us detect dementia earlier, monitor better, and importantly, open up interventions earlier? Now, before I go on, I wondered if you might be willing to raise your hand if you've brought one of these today. Who's got a, oh my gosh. So that's pretty much all of us, isn't it? And that's very powerful because that means that we have something in our pockets that can measure brain health already. It can measure cognition, it can measure speech, it can measure movement. And we have it at scale. So we already have those tools that enable us in everyday life, outside research centres, outside specialist centres and clinics, to start to measure brain health. So yes, today I am going to talk about technology, don't switch off. But I'm also going to talk about people. I'm going to talk about you and me and our loved ones and how we can use that technology to really advance what us humans are good at doing, but can we see more clearly? Can we see earlier? And while we've been talking about technology, this isn't just about digital tools. I'd like to share a story with you. This is about my granddad, Patrick. He was born in Preston, which is in the north of England in Lancashire. It's a working mill town full of Irish Catholic connected families, and he was one of 10 children. He was the youngest. And it wasn't an easy start in life. Housing was cramped, money was tight. But he was bright. And he was so bright that he was offered a place at a very prestigious school in Preston, which is Preston Grammar School. Now, this was going to be a turning point in his life. It was a boys' school, high academic standards. The boys went on to university. But he couldn't take that scholarship. Do you know why? It was because he didn't have enough money for the uniform. In fact, his parents did have enough money for the uniform, but it was the school shoes. They didn't have enough money for the school shoes. So he turned that scholarship down, and that opportunity was lost. He went on to live a good, long, happy life, though. He worked in an array of jobs, mostly as a bin man. His friend next to him, smoking, chain smoking, in a time when people didn't know those risks. And later in his life, he went on to develop lung problems and then vascular dementia. But for me, that's not really how I remember him. As a little girl, I remember riding on the crossbar of his bike. He never learnt how to drive, and we'd cycle into town together. And he always encouraged me to learn and said, let's go down to the Preston Library, Jane. Let's keep learning. And this is my granddad and me, aged 3 and 18. I think my cuteness probably peaked at about 3. And I did work hard. I went to the local public school in Preston, and then I was fortunate enough to win a place at Cambridge University. And I went on to study medicine, and I loved learning, and my granddad kept on visiting me all the way through university and was so proud when I graduated. And then I went on to study neurology. As you've heard, I was really keen to learn about diseases of the brain. And I was a junior doctor. You might have heard of the National Hospital for Neurology in London, Queen's Square. I was a junior doctor there, much younger, learning about the brain. And it was one morning that I got a phone call very early in the morning. That's never a good sign, is it? And it was my mum, and she told me, Granddad's died. And I remember hopping on the train and getting that 3-hour journey back up north, and there'd been a snowstorm. The snow was falling, and I was looking out of the window. I was thinking about his life. And what became really clear in my mind was that Grandad had changed probably 10 years before he developed the memory problems. He'd started to slow with his walking. His hands didn't have quite the dexterity when handling money. His face had changed. His voice had changed. And I didn't realise it at the time, but those observations, that movement was changing before memory, would really go on to shape my career, both as a clinician and as a researcher. And looking back now, that really stays with me. Those changes in his movement were there. They were there before the memory problems. And it made me wonder, what if we could have spotted those changes 10 years earlier, before the memory problems, before it became obvious, before it changed a life? Not only with precision, but could we have done that at scale so that it was accessible even for people like my granddad that might have not had the easiest start? And actually, all of us are very good. As humans, we're very good at spotting changes in movement. I bet, you look into the distance and you can spot somebody by the way they walk. But if I said to you, how? What is it that you're seeing? That's much harder. It's much harder to bring it down to quantification and describe exactly what those movements were. And in neurology, we're trained to look for those movements. We're trained to ask, is the walking slow? Do the hands move in a certain irregular rhythm? Does the face change? Does it not express movement in the way it used to? But even as clinicians, even as movement disorder specialists, we get it wrong. We're not actually that precise. We can say it's slow, but not how slow. And that really was what dragged me into research, that I thought, I think we can do better than this. So, as you've heard, I undertook a doctorate, a 2-year research degree at the University of York, and we were putting on wearable sensors onto people with Parkinson's. And as many of you will know, Parkinson's, which is the second most common neurodegenerative disorder, we start to see slowed movements. So through using these wearable sensors, we were asking, can we quantify those different movements? And I think it's important to say, although we say movement is slow with Parkinson's, there's actually other components. So there's a smaller amplitude, there's an irregular rhythm. When people are tapping, they don't tap at the same amplitude and speed, but it gradually decrements. So actually, there's 4 components that we're trying to look at all at once. And is it any surprise as clinicians that we miss those details, that we need something to help us quantify the movements? So that moves me on to AI, artificial intelligence. Now, immediately I can feel a change in the room. Some people are rolling their eyes, some people are looking excited, some people are thinking, I just hope she doesn't explain that too long because I wouldn't mind my lunch. So I'm going to keep it quite high level. AI is actually all about spotting patterns. So that's spotting patterns in data. And then there's these different subcategories, machine learning and deep learning. But ultimately, it's all to do with, can we pull out patterns from quite complex data? So you could say that actually AI is just extending our ability to see patterns as humans. I won't go into too much detail, but this was one of the types of AI that I used called evolutionary algorithms, and it's really based on nature. So you give the computer some data, like the finger tapping data I mentioned, and you ask the computer, can you tell me what's the difference between the people with Parkinson's and those that are controls? And effectively, the computer just churns out a load of random solutions. And then what it does is it takes the solutions that seem to be working better and combines them together to see, can you get an even better result? And it iterates this hundreds or thousands of times until the results get better and the optimal solution pops out. So I've simplified it there, but hopefully you can see that really it's all about trying to find patterns in data. So if we take that one step further now, we realise that actually signals and patterns are being picked up all around us all the time by our devices, aren't they? Right here now, there's laptops, iPads, smartphones, cameras, and it's very similar at home, that all these sensors are actually measuring things. Just imagine if we actually took all of that continuous data and used it for good, used it to try and channel and improve detection of brain health. But that can feel a bit uncomfortable too, can't it? Who is listening to us? How many times have you looked something up on your smartphone and then you've been bombarded with adverts for something really similar? That feels strange. Or the algorithms work out that I'm coming up to 50 and I might want a facelift overseas. Not entirely pleasant, some of the assumptions, but there's a serious note as well, isn't there, of who owns that data? What's the bias? What's the control? And these are things that we really need to think through carefully, and there are now data protection laws that come in, such as GDPR, which says the data, you own your own data. So we are catching up, we are protecting us humans from technology. And actually that's an important point, that technology can't really do anything without us. I think we shouldn't shy away from it. We shouldn't ask, is AI good or bad? But actually, how can we use this technology for something that's good, something that we need? So why does this matter anyway? Well, I know I'm talking to a learned audience, but it's really important to highlight that dementia, most brain disorders don't begin at the point of diagnosis, do they? They've been there for many years, if not decades before. And we have these prodromal stages in dementia of mild cognitive impairment and subjective cognitive impairment, and in Parkinson's similarly, REM sleep behaviour disorder, and with both conditions a long preclinical period where we're not picking up any signals. Just imagine if we could. That gives us a 10-year head start on what we could do, how we could intervene. The other issue that we have is that us humans, even if we develop the same condition, we develop it in different ways. Our trajectories, our pattern of changes are different, and that's a hard pattern to spot. It's hard for us humans, it's hard for us clinicians, and actually computers are pretty good at that. So in 2019, I moved to Tasmania, a very different setting geographically and clinically. And in that change, a question started to emerge that what I'd been looking at for years as a Parkinson's specialist around movement, could it be that I could use that to actually try to start detecting dementias earlier too? And actually, it's just the flip side of what happened with Parkinson's, that for years we were told this is a movement disorder, and now we know those non-movement symptoms are very much part of Parkinson's. So as you've heard, one of the roles I took was to help set up the Island One-Stop Clinic with lots of support from ADNET. And really, this was set up because in Tasmania, there were a lot of people with dementia or cognitive symptoms that couldn't easily access those services. But it was in that clinic that I went into the waiting room and with fresh eyes thought, gosh, some of these people have really similar movements to Parkinson's. They're moving slower, their voices are softer, their faces are not expressing as much. When did that start? Could that have been in MCI, SCI, or even preclinical? And as part of my earlier work, I'd used something called computer vision, which is another AI tool really to do with spotting patterns. You can see here that the computer begins to understand what a finger and a thumb looks like and can track those movements. And it can do that offline, producing really similar charts to the ones you've just seen with wearable sensors. Or it can actually now do it online in real time. So these are just using these sorts of tools that we've all got in our pocket, but now it's giving us quantification in the clinic. And actually, that gave us a way in to start to think, how can we start to measure these different brain functions, not just movement, cognition and speech too, in the clinic, in the Island Clinic. And so we built this tool called TasTest. It's not very original really, is it, Tasmanian Test, but it's what we came up with at the time, and we're still thinking about a better name, and it's sort of stuck. But effectively, what is TasTest? It's a self-administered tool. It's been designed to be done by the person themselves, because that gives us great reach, that people can do it at home or on the bus or in the clinic. They don't have to keep coming into specialist centres. And I've shown one of the tests here where we get people to tap a sequence with their fingers, or they might just tap like this, and then the computer is extracting all of that rich data, the speed, the amplitude, the rhythm, although it's actually only a 10-second test for the person. And so it might be a movement test of the hands, it might be a movement test of the mouth, asking people to say pa, 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 pa regularly, or it might be a more standard cognitive test. But we really wanted to combine a suite of tests so that either we could just pick out individual tests that might end up being very discriminatory, or more importantly, combining them to start to get more of a picture more broadly of brain health. So from TasTest, we can extract, as I've mentioned, 3 broad categories of brain health information. We can extract information about movement, a suite of cognitive tests, more like memory and language and so on, and also speech. So that could be the motor elements of articulation, or it might be more the language elements of the content. But this is the important point, that we bring those that digital information together to form a digital fingerprint. So by that, I mean an individual profile of how we function as humans. And if you can do that at baseline or as somebody's aging, that's really useful then to work out when things are starting to change in the earlier stage, the preclinical stages of different brain disorders. And for the purpose of time, I'm not going to go into all the different tests, but we have started to develop other tests. Some members of the team here are in the audience, and I would encourage you to have a look at their posters. But we're looking at facial movements, we're looking at eye movements, mouth movements, and so on, to see can we broaden that out and make it even more accessible. I have had people really keen saying, I've had my hand amputated, I can't do TAS test. And genuinely, that's good to think about. You know, how can we make that test accessible to that person too? Maybe put a different movement test in, like a movement of the mouth. So is it working? Can people actually do it? The first question is, can people do this at home? And I think the answer is yes. We've had just over 2,000 older adults take TAS test at home multiple times. And the completion rates are really high. They're never going to be perfect for a self-administered test, but they're high. And I think this is a key point, that even people with low computer literacy, low education, they also could complete TAS test. It took a few iterations for us to get there, but that's an important point for accessibility. This is Renji Lee's talk later on. Renji's one of the postdocs. But really, this particular piece of work was asking, can a really simple 90-second motor test, that's getting people just to tap their fingers and thumbs or do a sequence of taps or tap the keyboard, just 90 seconds of data, how well can that discriminate people across the clinical groups? And I think you can see here it's quite remarkable how well that discriminates. And the beauty of movement is that it doesn't depend on culture or education or language. It's universal. We also asked whether the TAS test components were associated with underlying biology. So we compared the movement features from TAS test to a blood-based biomarker, p-tau181. This is Guan Huang's talk later today. But in summary, what we found is that yes, it is associated. It does improve the estimation of p-tau levels. And not surprisingly, if you take both movement and cognition and speech together, it does that even more. So it's been really exciting to see TAS test move beyond that original idea. It's now being used in other brain conditions across most states in Australia. And I'm very grateful to the collaborators here that have tried it out in their own clinics, in their own research studies. It's also been used in clinical trials, piggybacking onto those trials so that we can validate against other measures. And what we're beginning to see, but this is sort of work in progress, is can we use those simple components like finger tapping to actually start to discriminate different brain conditions? I'm just showing you here that the speed of closing on the tapping cycle seems to be different across the dementia continuum from Parkinson's. But if you and I looked at it, we'd just say it looks slow. So that's where the computers are really giving us that discrimination. So, would that have been able to help my granddad? Could we have detected some of those signs earlier? Could we have seen what was coming and tried to modify risk or intervene? It's hard to know, isn't it? But I think what is helpful is that we could say, assuming this had been around, 50 years ago, that it's an accessible test. And I think I've always very much designed this test in mind, making it accessible wherever you live, whatever your background is. And so, of course, we don't just want to detect, do we? We now want to intervene. All of you know this figure here. We know that dementia is modifiable. But actually, when you look at the statistics in the public and in the healthcare profession, this information is still not getting out there. So how do we marry together detection with intervention? Well, many of you will know James Vickers, retired director of the Wicking Centre, very much has led the MOOCs, the massive open online courses, which really have become a global phenomena. And many of these were based around understanding dementia, preventing dementia, but there's now a suite of MOOCs. And really, this is about taking and scaling up brain health education. And one of the important projects has been the Island Project, which really is so simple but so effective. And that's saying if you administer the MOOC to a group of people or ask them to do it, and you combine it with personalised risk profiles, saying, this, you know, you're quite high risk on alcohol, but quite low risk on physical activity, try and lower your alcohol. The combination together is really effective. It can reduce risk factors by 25%. So all of this really is digital. It's allowing us to scale up at a population level. I seem to have lost my slides. I'll skip ahead, see if they're there. I'll continue while the AV guys try and see where my slides have gone. But the point I was trying to make there is that actually the education is a digital tool, the detection is a digital tool, and if we can bring those together, we have something incredibly powerful. I can actually just see them there. If you just go to the world one, that'll be great. Just go one back, please. So you might wonder, do people want to know their risk? And this is some work led by ADRF2026, again, that's being presented here at the ADRF. And this is a nice piece of work called Insight, and it's the next piece of the Island Project, really, saying, okay, you've given us blood, we know your blood-based biomarkers, we know your genetic profile, we know your cognitive profile. Do you want to know that, or is that going to cause a lot of anxiety? And actually, the answer is people really do want to know that. And when we ask them why, it's so that they can do something about it. They want to modify risk. They feel more motivated to modify risk if they know their own personal risk. So bringing all of that together, scaling up to really not only detect brain health at scale, but intervene. You can see we have the tools now. Certainly TAS test is not the only tool to detect risk. I've presented on that today. There's many others, but we do have the digital tools now to detect risk at a low-cost population scale. That's allowing us to understand the conditions better, but it's also, most importantly, allowing people to have that information back, to own it, to have agency, to take action, to intervene. And that's how we will improve brain health. Sharing that knowledge amongst the people, not just in the specialist centres. But this future's not automatic. With these tools come responsibilities, questions about trust and equity and access. We must be hopeful, but we must also ask, who does it serve? And just importantly, who might it exclude? Because if we are not careful, we risk building new forms of inequity on top of old ones. But if we get this right, we have something extraordinary. And that brings me back to my granddad. He was a man full of ability and intelligence, but his life was shaped by something as small as a pair of shoes. He wasn't excluded because he lacked ability. What he lacked was access. And in many ways, those barriers still exist today, less visible, but just as real. Geography, cost, language, complexity, time. So when I think about digital brain health, I don't just think about the technology. I really focus on access. If we can learn to see the earliest signals of brain disease in movement, in speech, in cognition, then we have an opportunity to detect earlier, to monitor more accurately, to diagnose earlier, and to intervene at scale. And importantly, to more people, not just to those that live in the cities near to the specialist centres. So I hope I've convinced you that this is not about replacing people with technology. It's about using that technology to serve people, to serve you and I and our loved ones better. And what do I mean by better? I mean earlier, more fairly, and at scale. What we really want is a future that is not just precise, but it's more human. I've left that slide there because, of course, no good research is done on your own. And these are just some of the people that have very much helped our team along the way. Some of them are here today, some of them are presenting posters. Now, I'd really encourage you to go and meet our team. We're a nice, friendly team. Thank you.
Thank you very much, Jane, for an excellent presentation. Running a bit out of time, but we've probably got time for a couple of questions. If you might want to come to one of the microphones, that would be great.
Hi Jane, Colin Masters from Melbourne. Brilliant talk. My colleagues and I have been working in preclinical Alzheimer's disease for a number of years. Yen Ying Lim and Paul Maruff were able to demonstrate that the first symptom of the buildup of amyloid in the brain is actually in the default mode network, which causes a loss of ability to learn, not memory deficit. And this has now been corroborated in other groups around the world. So the question is simply a digital test of learning, which may be as simple as a shopping list learning test, for example, and there are many other paradigms for learning, could be used as a pre-test of preclinical disease well before the p-tau goes up, which is a very late signal.
Yeah, it's a great question, and I couldn't agree more. I think the learning aspect is probably something that we're picking up a little bit in the motor tests that we're doing. It's interesting when we give slightly more complex motor tasks around dual tasking or sequences, those do seem to be harder. And is that partly because we're bringing that learning in? I think the more standard cognitive test of learning a shopping list is certainly really sensitive, and I'm really excited by that work. I think one of the beauties of the movement test is how incredibly brief it is. And even with a shopping list, there is still that cultural element. And I think I'm really excited by the fact that just something as simple as tapping the fingers, and we're actually looking at 5 seconds of data, that really seems to be able to discriminate people across the continuum. So I think it's a very exciting area to be working in.
Thank you. I don't see that we have any more questions, and that's probably fortuitous because we are out of time. But please join me in thanking Jane for her wonderful, insightful presentation. So next up in the grand ballroom will be the symposium with the Australasian Delirium Association, presenting on delirium and dementia. We also have oral presentations happening in the maritime rooms. Please refer to the agenda on your event app. So again, thank you very much.
Hello and welcome to ADRF's first symposium on delirium and dementia, presented by the Australasian Delirium Association. I'm really looking forward to today's session. We have 4 excellent speakers. My name's Andrew Teodorchuk, and I'll be co-chairing today's session with Anita Nitchingham. I'm an old age psychiatrist by trade, and Anita's a geriatrician, and we are respectively the President and Vice President of the ADA. Before starting, I'd like to acknowledge the Gadigal people as the traditional custodians of the land where we are today and pay respects to elders past, present and emerging, as well as to Aboriginal and Torres Strait Islander people here in the room. I'd also like to recognise those with lived experience of dementia and delirium and the distress that they experience. We strive very much to work in genuine partnership in all that we do, honouring the voices of people with dementia and delirium by centering their experiences and expertise. Okay, so welcome everybody. I'm really pleased that we're on the programme. I'm very grateful to Stephanie Ward for making this happen as well. Before I start, I'd like to hand over to Anita just to say a couple of words about the Australasian Delirium Association, which is growing from strength to strength. Anita.
Thanks, Andy. Thanks, everyone. We have a couple of slides just to introduce the ADA to people that might not be familiar with it. So we are a multidisciplinary group of people, so geriatricians, intensivists, anaesthetists, allied health, psychology, research scientists, and consumers. And our goal and our purpose is to improve the care and health and outcomes of people at risk of recovering from delirium. And we promote better understanding of delirium through leadership, education, support, resources, research, and partnerships. We have recently become a non-for-profit, so we have a board and we have 5 working groups at the moment. So there's the research working group, the education group, the marketing group, consumer partnerships, and the events group. And I suppose that the major thing that we run is the Declared Conference, which runs every second year. And so the next conference is going to be in 2027, October 2027 in Melbourne. And we've just booked the Ridges. And I think there is going to be an emphasis on the relationship between delirium and dementia. So hopefully that piques your interest. We also run a masterclass in the years in between the conference. And they cover a range of topics like intensive care delirium and pathophysiology of delirium. We've got one coming up in New Zealand in October this year. And we also run some workshops, a journal club, podcasts and more. So if you're interested in joining our mailing list, you can just head to delirium.org.au. I'll hand it back to Andy.
Thank you very much, Anita. Look, let's move on to the first speaker, Dr. Amy Montgomery. I'm really delighted to welcome her. Amy is a postdoctoral research fellow at the University of Technology, Sydney, and an aged care nurse practitioner with clinical expertise in dementia and delirium. Her contribution to the fields include the development of simulation-based delirium education programs, validation of delirium monitoring tools, and evaluation on non-pharmacological interventions. She's currently working on a program of work developing and implementing delirium prevention and recovery models for older people. She is also the very busy secretary of the ADA. So please join me in welcoming Amy.
Sorry, I have to have my notes with me because I'm blind and there's no way I'm going to be able to see that. So just bear with me. Hi, I'm Amy, and I'm here to introduce at a very high level the interface between dementia and delirium. Delirium is not transient, and it appears to be a particularly important turning point for brain health. So I'm maybe talking to the converted here, and maybe most of you in the room know what delirium is, but I'm just going to assume for a second that none of you have heard the word delirium before, and I'm just going to briefly explain it to you. Delirium is an acute neurocognitive disorder. It is an acute onset and a fluctuating course that changes from a person's baseline. It has characteristic signs of inattention, disorganized thinking, and altered level of consciousness. And it is quite often under-recognised and underdiagnosed, particularly in people with dementia, because it's assumed that that's their normal cognitive baseline. It is a multifactorial underlying cause, quite often infection, medication, environmental changes, electrolyte imbalance, pain and constipation, and it affects up to 1 in 3 people in hospital. That rate is higher for older people and even higher for people with dementia. Despite its frequency and severity, it is quite often invisible in our healthcare system and even more invisible in our community environments. It is not a transient condition, and we have increasing evidence that shows that there's increased mortality, functional decline, higher risk of institutionalisation, long-term cognitive impairment, and an even growing body of evidence that shows that delirium is highly associated with incident dementia. Delirium is also significantly associated with 90-day mortality, higher than those who do not experience delirium during their hospital admission. It also appears that it may be a marker of poor prognostic indication, particularly for those without an existing diagnosis of dementia. They have a even higher mortality rate after experiencing delirium. There's this growing body of evidence that there's this bi-directional relationship between delirium and dementia, and it almost becomes like a vicious circle domino effect. Delirium increases your risk of developing dementia, but dementia increases your risk of delirium. And the more episodes of delirium you have, the more likely you are to develop dementia. Then with your dementia process, you're more likely to develop a delirium. And it becomes this ongoing cyclic process of devastation for people who experience delirium. Now, I'm going to present a very high-level overview of the pathophysiology because we're going to hear from Gideon and Ellie, who are going to provide a deeper dive into the pathophysiology of delirium with the interface of dementia. The underlying pathophysiology of delirium is very complicated and complex, and mechanisms linking delirium with incident dementia are currently under debate, and it's a really interesting and growing research field. Delirium may be an epiphenomenon. It might uncover unrecognised pre-existing or preclinical dementia, or it might cause dementia by accelerating underlying neuropathological processes or de novo mechanisms. The development of delirium might be an expression of a balance between brain vulnerability and brain resilience, and that resilience is related to the ability to maintain cognitive function in the setting of an insult or a precipitating factor. In people without cognitive impairment, delirium may reflect a larger physiological insult, making it a more specific marker for severe acute illness. Delirium may be the first event or manifestation of reduced brain resilience in people due to subclinical neurodegeneration, small vessel disease, genetic susceptibility, or other susceptibilities that aren't captured in routine measures for people. We do know that delirium recovery, particularly in older people, is very incomplete. And up to a third of older people are actually discharged from hospital still in an active state of delirium. We also know that at 6 months post-recovery, people, particularly older people, are still experiencing a delirium. And I have witnessed this myself on a very personal journey with my dad, who had a bilateral knee replacement 18 months ago at the age of 61, had an unrecognised delirium. No one spoke about it. I diagnosed it in him myself, and still 18 months later, he's never returned back to his cognitive baseline. I can have a full conversation with my dad, and the next day he wouldn't even remember talking to me. He's 61. He's lucky that I understood what was going on, but how many people in the community get discharged with a delirium? The families don't know what a delirium is. They don't know how to do delirium recovery, and that person has a significant downward cognitive and functional decline. My dad hasn't even retired yet. We have done systematic literature reviews, and one in particular is under review, showing that there's a huge gap in delirium recovery models of care. And we are going to hear from Hannah shortly, who's going to explore one of the amazing growing programs of research that we have in Australia around delirium recovery. We actually need to join forces between the delirium and dementia world. All of us in this room have a very important role to play in how we can align our research and our recovery models of care to better service the people who experience delirium during their hospital admission. We also believe that prevention is the key here, because if we can prevent delirium, we might also be able to prevent dementia. And it's really critical that we come together. Just to summarise my talk, delirium is a turning point in brain health. It's quite often an indicator of underlying brain vulnerability. We do know that people who have a dementia are likely to develop, who have a delirium are likely to develop a dementia. We need to prevent delirium as much as possible. We might be able to prevent dementia. We need to recognise delirium earlier, because if we can intervene earlier, we are likely to stop that dementia process from occurring. We need to follow people up long term and provide post-diagnostic models of delirium recovery. And we need to come together as researchers to develop new critical pathways. Thank you.
Thanks very much, Amy. I think a beautiful snapshot of where we're at the moment, and so much work to be done. If you have any questions for Amy, did you want to pop up to the mic? I guess I'll start. Oh, great. While you go to the mic, I'll just ask a quick question. So you've highlighted a lot of misconceptions about delirium. What do you think the major misconception is about delirium that you'd like to let everybody know? Because there's so many.
I think that people think that you just have the episode of delirium and then you're fine. Or it's only caused by one underlying cause, and quite often if you're an 85-year-old female, that's a UTI. And if you don't find the UTI, most often I see clinicians, probably not in this room, stop looking and just assume that it's because they're older, it must be normal for them. And it actually has significant detrimental impacts on them and their family.
Hi, Mark Yates from Ballarat. For those who Gideon will know, my question's going to be an obvious one. I set up the Dementia Care in Hospitals program, and we use the cognitive impairment identifier in hospitals, which we've got nationally. What I don't understand, I fully accept it, is that we are still talking about delirium and dementia as if they're different things, and yet at a functional level in hospital systems where we've got really experienced nurses who deal with function rather than diagnosis, we don't talk about cognitive impairment in hospitals. And do you think it's time we stopped talking about delirium and dementia in hospitals and start talking about cognitive impairment?
Oh, it's a great question, right? And I mean, we could have a debate about that all day. I think one of the things with nurses is they're quite often disempowered to write the word delirium in the clinical notes. And mainly because they assume that that becomes like a medical diagnosis, and if you're not a nurse practitioner, you're not allowed to do medical diagnoses. So they write things like pleasantly confused, or agitated, or resistive to care. And a colleague of mine, Dr. Kelly Marriott Statham, just published an amazing paper looking at a hospital in Canberra who actually looked at the wording that people use to describe delirium, and most of the time it was pleasantly confused. We don't call someone pleasantly breathless, do we? So I think it's more about actually using the words, because until we can properly code for delirium in the clinical notes, we're actually under-recognising that and under-representing it in research. And we don't also have a field of code of research for delirium. Until we can show it's this significant issue, we're constantly fighting for research funding.
I'm sorry, we don't have time for another question. But yes, if you could catch up afterwards.
And someone else might answer your question for you anyway.
Yes, and if we have time at the end, we'll definitely come back. So could everyone join me in thanking Amy for that fantastic talk? Okay. Delighted to introduce the next speaker, who is Professor Gideon Kaplan. He is my boss. He's also the Director of Post-Acute Care Services and Geriatric Medicine at the Prince of Wales Hospital. He's a conjoint professor at UNSW, and he really he started the Australasian Delirium Association. He's our previous recent past president, and really responsible for raising awareness of delirium and bringing a lot of clinicians together, and had some fantastic initiatives over the, 7 or 8 years that you were in charge. So really excited to hear Gideon talk today about the pathophysiology of delirium and dementia. Please make him welcome.
I'm sure Anita didn't just say that because I'm her boss. It was so nice to hear the choir this morning sing I Still Call Australia Home, because this talk is all about Australian research to the world and how we've led the world in delirium pathophysiology research. Delirium is a very old condition. It was described by Hippocrates 2,500 years ago, and we've known for a long time that multiple illnesses in the periphery of the body, everyone thinks of UTIs, but any metabolic illness, pain, drugs can cause delirium. And there were even experiments done that showed that peripheral metabolic stress in the body can also lead to delirium. What we did was show that there is a brain-specific metabolic derangement, which is not just a spillover from the periphery. And we found evidence of a switch from the normal aerobic to anaerobic glycolysis. So lactate is a byproduct of anaerobic glycolysis, and neuron-specific enolase is part of the aerobic glycolysis pathway. So this localized derangement in metabolism, which is not reflecting changes in peripheral metabolism, but it does correlate strongly with outcomes of delirium. And subsequently, 2 overseas groups have replicated this. Down the bottom, a group in Europe, and on the right-hand side, a group from the United States, showed that in their delirium patients, there was also an increase in lactate levels. Subsequently, in collaboration with a group in, we'll get to that, we've also shown that, for example, the lactate on your left, you can see the lactate levels in the CSF do not correlate with increased lactate levels in the body, so it's not a spillover. And the raised lactate levels correlate in the middle with the decrease in activities of daily living function over the course of the admission. And you can also see that people with delirium who died had higher levels of lactate than people with delirium who managed to get home. But then in collaboration with a group in Norway, we've shown that the metabolic derangement is wider. So on 3 separate markers of insulin resistance, we've shown that there's increased insulin resistance in the brain during delirium, as well as increased levels of ketone. So the brain is really struggling to find alternative energy sources. As was mentioned this morning, glucose is the main energy source, the main energy supply in the brain, and the brain uses 20% of the body's glucose to drive its functioning, even though it's only about 2% of the weight of the body. It's very metabolically active. So what we see in delirium is the brain is switching for some reason to alternative energy sources which are available but not as efficient. They don't work as well as just using glucose. So there was a wonderful review article published just in the last month in Age and Aging, which tries to integrate all this knowledge about metabolic derangement in delirium. And this doesn't mean that there isn't some inflammation and other things going on, but the primary driver of delirium seems to be this metabolic derangement, as I'll show you in subsequent slides. So we have done studies using FDG PET, glucose PET, which show that there's massive areas of decreased glucose metabolism around the whole cortex of the brain during delirium, apart from the sensory motor cortex, which I don't know if this laser, this little bit up here, the sensory motor cortex. The rest of the cortex is hypometabolic, but that's a combination of things, of the delirium, the acute illness, and in many cases also underlying dementia. So we did another great study led by Dr. Nitchingham, which isolated purely the effects of the delirium and controlling for the dementia and the acute illness, showed that there were 5 main parts of the brain that are hypometabolic, specific to delirium, and that they explain all of the symptoms of delirium. So the right superior frontal cortex, which is an important locus for executive function, but also lesions in that part of the brain have been shown to increase impulsivity. The thalamus is probably the central part of the brain for delirium because it controls what part of our cognitive inputs we focus on. So it's very important for attention, but it's also crucial for alertness because the thalamus sits at the top of the reticular activating system, which controls consciousness. The posterior cingulate cortex, part of the default mode network, temporal cortex, important for memory functions, and the superior parietal cortex, important for some spatial orientation. So we hypothesized that one of the ways we could hopefully correct partially the metabolic changes that are happening in the brain may be through intranasal insulin. And insulin in the brain has multiple effects, even though for a long time it was thought not to be present in the brain. We now know it has multiple good effects on brain function, which I've only got 8 minutes, so I can't go into in detail. But Dr. Nitchingham led this study looking at intranasal insulin to treat delirium. We recruited older patients being admitted through emergency with delirium and randomized them to either have intranasal insulin or placebo. And we found a non-statistically significant decrease in duration of delirium in the total group, but for some reason in the younger group, people aged less than 88, they showed a significant decrease in delirium duration, but not in people over 88, the slightly older young group. Interestingly, we did find a statistically significant decrease in length of stay of 5 days across the whole group, which it's interesting that if it wasn't directly related to delirium duration, there must be some other way as well that intranasal insulin is helping people recover, which we don't really understand as yet. But as they say in the classics, more research is needed many, many times. And the amazing thing about intranasal insulin, because people are always worried about giving insulin to someone who's not diabetic, is that it's very well tolerated and very safe. And you don't get peripheral hypoglycemia from the intranasal insulin. That which doesn't go across the olfactory nerve into the brain seems to be metabolized in the stomach, and so hypoglycemia doesn't happen, and the other side effects are really minimal. So overall, and to sum up after a quick talk, there is considerable evidence that there is a metabolic basis for delirium on studies of CSF, FDG PET, other imaging, and also from the fact that it responds to intranasal insulin. But there will be more to come. Thank you.
Thank you very much, Gideon, for that insightful and elegant presentation. It's really good to see that program of research and the evolution as well. So if you have any questions, and we have someone already at the mic, please fire away.
Thanks, Gideon. Michael Woodward. It's interesting that the sensory motor cortex is spared, as it is in Alzheimer's disease too. And we know people with delirium can be running around the room and trashing the joint. But what about in hypoactive delirium? If their sensory motor cortex is working, why aren't they using it?
It's a very good question, and I don't know the answer to that. We do have some MRI imaging work which shows some differences between motoric subtypes of delirium, but that's not ready to present yet. We haven't seen it, we couldn't find a statistically significant difference in this study between different motoric subtypes, so I don't quite understand why though.
Are there any other questions? We do have a bit of time for extra questions as needs be. We have someone coming to the microphone. Please do introduce yourself and fire away.
So my name's Marta and I'm from Melbourne. I've got a really dumb question. Can you explain the procedure of intranasal insulin, and is it something that is can be implemented quite effectively, within healthcare settings as well?
It's a very good question. Intranasal insulin, at the moment, we just use a syringe which has a special aerosolizing cap that we can just squirt up into people's noses. So it's very easy to administer. It's not painful, it's not uncomfortable for patients. if we can show that it works, it could be extremely easily implemented across the whole world. Every hospital ward have little bottles of insulin ready to be squirted up people's noses. And they just need, at the moment, the aerosolizing syringes are quite expensive, but it's one of those things that people don't use them much. So there'd be economies of scale if it became proven as a worthwhile treatment. I have heard rumours that people are already using it off-label, offline. We're trying to build sufficient knowledge base to make it, part of guidelines and so that we can have decent meta-analyses.
Thank you. We have time for one last question. Oh, here we go. Over to you, sir.
I'm Ronaldo from Adelaide Hospital. Just like to know from you, before any metabolic change, we know that sleep alterations and sleep disorders as well play a central role in the pathophysiology of delirium. And your thoughts about the use of melatonin to try to prevent or treat delirium as well?
Sorry, I'm not sure. You're asking, is sleep a factor in delirium?
Yes.
Undoubtedly it is, yes.
Yes.
Disturbed sleep definitely increases your risk of getting delirium. Studies of melatonin in delirium have been done, which don't consistently show a beneficial effect, but I know there's more work ongoing.
Okay, right. Thank you.
Thank you. Thank you very much, Gideon. I don't know if you're aware of Jose Maldonado's spaghetti diagram of the pathophysiology of delirium. Hopefully one day, Gideon, you're going to put out something a little bit simpler to help us on our way. All right, introducing our next speaker. So we're a real MDT experience here. So we've heard from a nurse, we've heard from a doctor, now we're going to hear from a psychologist. Our next speaker is Professor Hannah Keeg. Hannah currently chairs the Australian Academy of Science National Committee for the Brain and Mind. She is also the co-lead for CANE, which is a Cognitive Aging and Impairment Neurosciences Lab in Adelaide, and her research focuses on cognitive aging, cognitive impairments including dementia and delirium, in cardiometabolic contributions to cognitive aging, the neurophysiology and the neuropsychology, of course, of delirium and delirium rehab. Please welcome Hannah.
Thank you. Okay. I should have printed out my notes like Amy because I don't have great eyesight, but I will make do. So my name is Hannah Keeg. I'm from the new Adelaide University. So any questions about the university merger, I'm also happy to take those. So I'm going to be talking about the Help After Leaving Hospital project, or HALT, which is a co-produced, scalable, multidisciplinary and tailored program to prevent cognitive decline after in-hospital delirium. So I'm just going to cover three things that are sort of fundamental to how we got to this project. And the first, that delirium is really common. So we see delirium in about 15 to 30% of older people in hospital. The second bit of background is that delirium is really serious. And it's not just serious at the time of delirium, but it's really serious after delirium has resolved. So we published this meta-analysis last year, and we compared older adults who experienced delirium in hospital with older adults who didn't experience delirium in hospital. And essentially, delirium was associated with every poor outcome you could ever imagine in an older person. So delirium was associated with high rates of cognitive decline, functional decline, lower quality of life, poorer mental health, high rates of incident dementia, high rates of institutionalization, revisits and readmissions, as well as a higher rate of mortality. This has collapsed over time, essentially any time after discharge. And the third point that really forms sort of the background of this work is that it's really delirium driving these poor outcomes. It's not hospitalisation. So Sarah Richardson, and I don't know if Bloss is in the audience, she's an author on this. she's an author on this paper. Sarah did amazing work embedding herself into an ongoing population-based cohort study in the UK, selecting the Newcastle site, and essentially for 12 months, Sarah went in, and every time one of these participants was admitted, she went in to assess for delirium. And essentially she had 3 groups, never went to hospital and had delirium, and went to hospital and didn't have delirium. And what she saw is that all of these poor outcomes I've been talking about are driven by delirium, not by hospitalisation. So it really begs the question, well, can we intervene in the context of delirium? And the answer is certainly yes. There's really good evidence for over 20 years that we can prevent around 30 to 40% of delirium cases. And this is all, you know, it looks straightforward, but it's actually really complicated. It's all about modifying these behavioural factors. So making sure people are sleeping well, that they're fed, that they're hydrated, that they're cognitively and socially stimulated, that they're as mobile as possible, and that they're wearing hearing aids and glasses if applicable. So we can prevent around 30 to 40% of cases. Why isn't this done all the time then? Well, really, a lot of delirium, like Anita's work, presents on admission, which actually makes delirium, their prevention, impossible. You can't prevent something that's already occurred. Also, these behavioural factors also, although they seem sort of straightforward, they're actually really logistically tricky to implement in an acute care setting. And I mean, this is the Delirium Association Symposium, but delirium's not always everyone's clinical priority. So that's just it. And also delirium's a bit of an orphan condition. So if you have a heart attack, you might see you'll definitely see a cardiologist. If you have a stroke, you'll see a neurologist. But if you have delirium, there's no sort of disciplinary home there. We can see delirium in all patients across the whole lifespan. That sometimes it can sort of be lost. So, delirium prevention, lots of evidence that we can intervene before delirium's occurred to reduce incident delirium. As a group in Adelaide, we thought, well, can we use all this evidence we have from delirium prevention, but also from dementia prevention and cognitive decline prevention to try and work out a delirium rehabilitation program. So delirium rehabilitation is, can we reduce decline after delirium? That is, can we intervene after delirium has resolved? So this brings us onto the HALT project. I can see Steph's in the audience, and I know Sally's here at the conference. So it's a wonderful group of people who have worked on it so far, and I know the group is growing. Anita and Amy are going to join us next round, but we were fortunate enough to get funding from the Hospital Research Foundation in South Australia to develop this between 2024 and 2025. I'm going to summarise that 2 years of work essentially on a slide. We got all the scientific evidence around delirium prevention, dementia prevention, and cognitive decline prevention, and mixed that up with the views and experiences of consumers and healthcare professionals. We then went through sort of an iterative program development phase, developed a draft program, and then we took that draft program to the consumers and the healthcare professionals to get their views and their opinions and some feedback and basic acceptability testing. So principles underlying the HALT program, it's offered to anyone over 65. We've chosen to have people without dementia. We can talk about that. After discharge, but it started whenever someone is ready. So that could be a week after discharge, it could be a month. It is tailored and multidisciplinary, it's modular and scalable, it's modular and sequential, it's scalable with remote delivery, it's underpinned by behaviour change science, so there's a lot of psychologists on the group. it's co-produced, and it's non-pharmacological. So what does this look like? We have 3 what we call essential modules, which is delirium education, medicines and vision and hearing, and then we have 5 optional modules, which are sleep, well-being, physical functioning, cognitive health, and nutrition and hydration. Really need to work on that vision myself. We've also developed a support persons booklet, which isn't a module in itself, but a resource that really came through in all of our co-production work. So here are 2 fictional people. Our first person does delirium education, vision and hearing, medicines, well-being and sleep. Our second person does delirium education, cognitive engagement, nutrition and hydration, and then they end. So I hope you can see that it's modular, sequential, and tailored. I'm out of time. Where have we come from? Where are we going? So in 2021, we actually did some initial consumer engagement and developed this project. We've been fortunate to get the funding from the Hospital Research Foundation to develop this program. We've now received funding from the Northern Community Health Research Foundation to do acceptability and feasibility testing, and we are crossing all of our fingers and toes that we can get some MRFF funding to do a hybrid trial in the future. Essentially, we want a high-quality care pathway for older people after in-hospital delirium. So to end, we think this could have a huge impact on older people. This is a really high-risk population. It's a really big population. And what we've done is co-produced with those who it will affect. So if it is effective, I mean, that's pending the efficacy trial, but we think we have a huge potential to drive a substantial care shift and address standard 8 of the clinical care guidelines. So thank you so much. Sorry for being out of time, and thanks to all the team as well. Was I 13 minutes? Oh my God.
We're running a bit early.
Okay.
Thanks very much, Hannah. That's a very exciting space. Does anyone have any questions to ask? I will ask. What do you think defines good recovery from delirium? And do you think this kind of, the whole project is going to be appropriate for patients with underlying dementia and maybe persistent delirium?
So I feel like the delirium field is vexed with many R's, so resolution, resolving, and rehabilitation. We have designed this to be suitable for people who don't have dementia before their hospital admission, acknowledging that there's lots of unrecognised dementia, but that aside, those without dementia actually have the most to lose after a delirium. That's shown by Dan Davis's work. So we chose to go down that route. I would hope that if we can continue this project, we can actually expand it out, but I think the materials will be different for those with dementia.
Sorry, thank you very much, Mark Yates from Ballarat. Fascinating and important, and I guess our service is one of the few that are the accredited help providers for delirium. My question really is about this post-delirium effect, and it didn't seem to me that you had primary care built in to this model. At the very beginning, we heard how important chronic diseases are in the setting of delirium. And we know that if we've got people with chronic disease and any degree of cognitive impairment, that chronic disease fails, and then that precipitates a delirium. So if we're going to do anything post-delirium, shouldn't we actually be engaging in the primary care health space?
Absolutely. There's so much there, and I think I could talk to you for a long time. There's a few things. We decided that we wanted to produce something that was scalable, that didn't need primary care, but that would be a great model of care and something that Amy is developing more closely. We did integrate GPs into our co-production process, but there is so much there to tackle, not just rehabilitation. So discharge summaries rarely have delirium on them. No one ever goes to the GP and says, oh, someone mentioned I had delirium. So I think there's a lot of work to be done in that sort of acute to primary care space, not just this program.
All right, thanks very much, Hannah. Will you join me in thanking Hannah? And our final speaker for today is Associate Professor Ellie Marta. He is from the University of Sydney and a consultant neurologist and sleep physician at the Royal Prince Alfred Hospital and the Woolcock Institute of Medical Research. Ellie's research focuses on dementia with Lewy bodies, Parkinson's disease with a particular interest in sleep-wake circuitry, fluctuating consciousness, delirium and biomarker development. And he leads the sleep, wake and neurodegeneration group. Ellie serves in executive and editorial roles within national and international neurological societies. Will you please make him welcome?
Thank you so much, Anita, for that warm welcome. And it's really a pleasure to be part of such a fantastic panel talking about the interrelation between delirium and dementia across all stages. What I'll be talking about is bring your attention to delirium as maybe an early sign of dementia with Lewy bodies. Rather than talking about dementia more broadly, I want to focus particularly on dementia with Lewy bodies, which is something that I have an interest in and want to study. These are my disclosures. So, quick recap, what is dementia with Lewy bodies? So, we often say it's the second most common neurodegenerative cause of dementia in the elderly, but basically its underlying pathology is phosphorylated alpha-synuclein that clumps up inside cells, and there's an associated selective loss of cells throughout the brain. It's selective in very specific parts of the brain, not just those areas that have Lewy bodies. And then there's some sort of combination of Alzheimer's disease-related pathology. So that's the pathological hallmark. The prevalence is somewhere between 5 to 15%, depending on how close you look in these clinical populations, but it's frequently misdiagnosed. So those cohorts where they've had actually a neurological assessment looking for motor symptoms of Parkinsonism, they tend to have higher estimates clinically. But when you look at autopsy, it's generally present in about 50% of people, and the primary driver of pathology is somewhere between 15 and 24%. So it rises significantly when you look at neuropathology. It has a number of risk factors, including age and, of course, genetic risk factors that sort of are shared between both Parkinson's and Alzheimer's. And it has a poorer prognosis in comparison to Alzheimer's disease. Higher institutional rates, increased mortality, increased care partner burden, and that's mostly because of the non-cognitive features that you often see with this disorder, which we'll go into next. So, a recap about the diagnosis of DLB. So this is the core feature framework that's been in place since about 1995, and this is the fourth diagnostic revision, and we're now revising it into the fifth diagnostic revision for dementia Lewy bodies criteria. What you need is dementia, defined classically, and two or more core features, usually cognitive fluctuations, which is the first core feature of dementia Lewy bodies, well-formed visual hallucinations, Parkinsonism, and in 2017, the introduction of REM sleep behavior disorder, so inappropriate dream enactment, as a core feature of this disease. There's a one-year rule, which I'm not going to dwell about, which tries to separate Parkinson's disease dementia and dementia with Lewy bodies, but that line is quite blurry. And also, they introduced objective biomarkers, and these are worth paying attention to. These include things like polysomnography confirmed REM sleep without atonia, so elevated muscle activity during REM sleep when you're supposed to be paralyzed, so the physiological correlate of REM sleep behavior disorder. Reduced dopaminergic activity based on something like a DAT scan, F-DOPA scan, and low uptake on cardiac scintigraphy. And interestingly, I always point this out, but if you have dementia plus REM sleep behavior disorder clinically and validated physiologically, this criteria allows you to make a diagnosis of probable dementia with Lewy bodies just on that feature alone. There's also a number of supportive features, which on their own are not very specific, but I use very much clinically to help figure out if the person in front of me has a synucleinopathy, because the constellation of these features are actually quite helpful in thinking about synucleinopathy, especially when there's a cluster of them. And they range from things like neuroleptic sensitivity, transient loss of consciousness, severe autonomic dysfunction, hyposmia, and objectively, things like reduced occipital and parietal uptake on FDG PET, preservation of the medial temporal lobes on MRI, although if you have medial temporal lobe atrophy, you could still be DLB with AD co-pathology, and EEG slowing, especially posteriorly. So why am I talking about DLB? Well, in 2020, of course, we know that a lot of these features and a lot of these disorders start many, many years and decades before we finally diagnose them with dementia. And the first formalized criteria for prodromal DLB came out in 2020. And they identified 3 prototypical prodromal DLB syndromes. And that included the mild cognitive impairment Lewy bodies, which is essentially just translating mild cognitive impairment into the criteria. And there you go, that's mild cognitive impairment with Lewy body. But also 2 additional ones, delirium onset DLB and psychiatric onset DLB. And for the remaining portion of my talk, I just want to focus on delirium onset DLB, because why delirium onset DLB? So if you look at the evidence epidemiologically, delirium commonly precedes diagnosis of DLB, and perhaps more so than Alzheimer's. DLB patients are 6 times more likely to have had a diagnosis of delirium in the year prior to their diagnosis. A quarter of DLB patients have had at least 1 episode of delirium prior to diagnosis. And a quarter of those patients are more likely to have had more than 1 episode of delirium, so recurrent delirium is quite common. And there's a much higher incidence of delirium in the year before and after a diagnosis of DLB compared to Alzheimer's. So that already suggests that there's a specific peculiar vulnerability of DLB patients to delirium. The other reason is there's some imaging and EEG features to suggest some overlap. So there's FDG PET imaging studies of people with prolonged delirium found that 1/3 of subjects were found to have a DLB-like pattern with posterior hypermetabolism. And it's very interesting with Anita and Gideon's study looking at thalamic hypermetabolism, parietal hypermetabolism, which has also been shown to be signatures of mild cognitive impairment with Lewy bodies. People have looked at those with delirium and following delirium and persistent delirium to show that you can actually find groups of patients that have reduced dopaminergic uptake as well in some of these cases, especially where it's unexplained. And EEG slowing and reduced alpha reactivity is a shared hallmark between the 2. There isn't much work in biomarkers, but I always cite this really interesting study that got me interested back in 2013, where they took patients who are undergoing gastric surgery for gastric cancer, and they looked at those patients who developed delirium after the operation versus those who didn't, and they looked at phosphorylated alpha-synuclein, which you can find in the gut of these patients, and it was a lot more common in those who developed delirium than those who don't. So that was a little hint. Now we have much better synuclein biomarkers, both skin immunofluorescence immunohistochemistry and seed amplification of synuclein on skin and in the CSF, which have yet to fully come to Australia and have not been looked at in this cohort. And there is a clinical overlap. So the thing that I have a lot of interest in is cognitive fluctuations. And if you look at the definition of cognitive fluctuations, which is variations in alertness, in cognitive abilities, often associated with arousal changes, it is almost exactly what is the phenomenology we describe with delirium, without maybe that medical precipitant. So that got me thinking about the shared pathophysiological overlap, of which there are many proposed, which I won't go into. And also it is very difficult to discern the difference between sometimes delirium and DLB, especially in the acute state, where you might have, say, hyperactive delirium, visual hallucinations, attentional disturbance, and executive dysfunction. But there are gaps and more evidence is needed. We don't have enough evidence to guide any formal operationalized criteria for this delirium onset DLB which was proposed. So it's kind of just a suggestion in the criteria at the moment. And we don't really understand that shared pathophysiology. We've tried to look at this retrospectively in a case of 34 caregiver dyads and patient dyads in our cohort who've come through a neurology clinic. And one thing that I like to draw attention to, well, we found at least a quarter had an episode of delirium before their DLB diagnosis, and maybe 9%, so 3 of those patients had just delirium as the first marker, but 3 out of the 4 actually had RBD before that as their core feature, which was not diagnosed. So that's interesting to look for RBD. And the other thing, someone mentioned sleep, which is something I love, of course. The really interesting and most common trigger for delirium that these caregivers identified, albeit retrospectively, was long-haul flights with potentially implicating circadian disruption and sleep deprivation. And then the final thing to say is that we are now trying to look at this prospectively with this delirium vulnerability for emerging LBD or DELV LBD studies. And what we want to do is prospectively characterize a group of patients who've had delirium or recurrent episodes of delirium, especially delirium provoked by maybe one particular illness or a minor unexpected delirium. And we're looking at both clinical, neuropsychological phenotyping, but now synuclein skin biopsies, which have started to introduce at RPA. So we can now look at biomarkers in this group. So I'm really excited to look at that. We'll also look at MRI and sleep to try to find these prodromal DLB cases and help with the definition of this. So my concluding slide is just some clinical takeaways. Delirium is common before a diagnosis of DLB, usually within the 12 months, and in our study also showed that it was a bit more of an aggressive course if they started with delirium. Consider DLB or prodromal DLB in those with recurrent, unexplained or prolonged delirium, or in dementia patients who had multiple episodes of delirium in the past. And in patients with delirium, a careful search for these features, both core and supportive, is a good idea. Paying particular attention, I think, would be interesting for those with delirium after long-haul flights, so something to look at prospectively. And I think we should do that because we want to avoid particularly antipsychotics that have dopaminergic activity in these groups, as well as, of course, anticholinergics, which you all know, and more studies are required to assess biomarkers. So thank you very much for your time.
Thank you very much, Ellie. I don't know if some of you know, but I worked in Newcastle upon Tyne for many years, leaving in 2016, so it's great to hear about DLB and see the work of Alison Young and Ellen Vardy as well. Excellent. Okay, we have a question.
Michael, again, Ellie, you're a very good speaker. You should speak at a masterclass at some stage. A quick
you
question.
hold that record.
Assuming the delirium doesn't cause DLB, and that is an assumption, why do you think DLB causes delirium? If you had to put your money on one possible pathogenesis.
It's speculative, and I have many, many slides that kind of go through that, and we've heard some overview that there are multiple mechanisms to delirium. Where I put my money is, and what I study is actually there's particular vulnerability of subcortical structures, particularly brainstem, noradrenergic, cholinergic as well in the basal forebrain, that are particularly vulnerable to Lewy body pathology. They're vulnerable in AD pathology, but you see more cell loss in DLB. And I think that it's a breakdown of that sleep-wake circuitry, which is important because one of the signatures is you get this kind of loss of an integrated state in the brain when you look at the brain dynamics with fMRI. And these structures modulate that entire brain state. So I think that's one component, but the other part of it that I also am suspecting more is a vascular component where they actually have a lot of dysautonomia and maybe are a little bit more prone with impaired cerebral vascular regulation in these groups. But we don't know. It's purely speculative, but that's where I'm putting my money, just based on kind of correlating neuropathology with the kind of global brain dynamics and the signatures that are shared between the two. But very open to other hypotheses.
And I presume sleeping closer to the front of the plane protects you?
I suspect so. If only we all could.
Very nice talk. I missed the beginning because the previous section.
You might want to just bring the microphone down.
Oh, okay, sorry, I missed a bit earlier because the previous section, different room and late. How do you, is your DLB is purely by clinical definition, or have you run the aggregation of synuclein to have a more biomarker support?
Great question. I don't want to talk about too much into the there's some debates around different diagnostic criteria for Lewy body disorders now, with Parkinson's now been proposing biomarker-based diagnoses, and that's caused a stir in the field, which is very exciting. In DLB, the criteria that I've just proposed are the clinical criteria, which include the biomarkers such as the imaging and the EEG, REM sleep behavior disorder, cardiac scintigraphy, dopaminergic imaging, but they have not introduced seed amplification assay or skin synuclein biopsy, which I was proposing yet. But I think that'll be the hot topic on the table as we're revising the new diagnostic criteria. So that will be coming. So I'm anticipating that with our study by trying to introduce synuclein immunofluorescence in these patients.
Yeah, I'm interested to see if your lab try to get the seed aggregation assay going.
No comment about that. I'm not doing. There are seed amplification assays. I know people are trying to get that going in different parts of Australia. Amprion, which produces the substrate, is coming to Macquarie. I know that in New South Wales. But what I'm doing is also the other one, which is the skin immunofluorescence and immunohistochemistry, which is much more easier to do. And we've got some positive data now. So we're still doing it in a research capacity, but hopefully we'll have both of these tests in Australia and using it for research and maybe clinical.
If there's no other questions, can we thank Ellie? Thank you very much for all that. Look, this has been a really terrific part of the conference. I do hope that the ADA get invited back, but it's been really fulfilling, and we've heard very different presentations as well, very enjoyable too. Please can we thank all of the speakers. In the spirit of Amy's calls coming together, I think we've achieved that today as well. I'd like you to very much sort of think about delirium and consider that interface with dementia as we move forward to help patients with both conditions as well. Look, lunch is outside. We're going to get there early, which is always good news. Enjoy the poster presentations and exhibition. The next session will begin at 2:40. Please check your app for the agenda and enjoy your food. Thank you.
It's been on my list for a while.